Meet Maya, 24 years old, a type 1 diabetic who ran out of insulin 2 days ago. She is nauseated and vomiting, her belly hurts, and she is breathing in deep, heaving gulps, with a strange, sweet, fruity smell on her breath. Her glucose is 642. Her blood has turned acidic, a pH of 7.16. And her potassium reads 5.8. Every instinct you have says the same thing. She is short of insulin, so give insulin, now. Hold that instinct, because it is the trap of this entire case. In diabetic ketoacidosis, insulin is not the first move, and giving it first, or before you check one particular number, can stop her heart. 1 patient. 6 decisions. Let's take them in order. Step 1. Recognize the cues. Start in the nurse's notes. A young diabetic, out of insulin, now vomiting, breathing hard, with that unmistakable fruity odor. Her body is in a metabolic crisis, and the chart holds 3 findings that, together, name it, plus 1 number that will decide the order of everything you do. So move through every tab, the vitals, the labs, the orders, the history, and gather the cues. Some of what you find will look reassuring and is not. Take it in, and pick out what actually matters. Open the Vital Signs tab. Her heart rate is 124, up, driven by dehydration. Her breathing is 30 and deep, up, and that pattern has a name, Kussmaul respirations, the lungs blowing off acid as fast as they can. Her blood pressure is 96/58, on the low side, and her skin is dry and tenting, the outward signs of a body that has lost liters of fluid. Nothing here is the emergency all by itself, but together they tell you she is profoundly dry, and that shapes your very first action. Now the Labs tab, and this is where the diagnosis and the danger both live. Her glucose is 642, sky high, her ketones are large, and her pH is 7.16 with a low bicarbonate and a wide anion gap, a severe metabolic acidosis. That triad, high glucose, ketones, and acidosis, is diabetic ketoacidosis. And now the number that changes everything. Her potassium is 5.8. Which looks high, even reassuring. Do not be reassured. In ketoacidosis, potassium has leaked out of the cells, into the blood, so the level looks high while the total body is actually depleted. The moment you give insulin, that potassium will rush back into the cells, and the level can crash. Now the Orders tab, and it is written in the right order, so read it as a checklist. Isotonic saline is ordered first. Wide open. To refill the tank. The insulin infusion is ordered, but notice the condition. It is to be held until the potassium is at least 3.3, and fluids are running. Potassium replacement is ready, to be given as the level falls. And there are hourly glucose checks. The orders themselves are teaching you the sequence, fluids and potassium before and around the insulin. Finally, the History tab. She has had type 1 diabetes since she was 9, and 2 days ago she ran out of insulin, the classic precipitant. There is no fever, no obvious infection driving this. It is the missing insulin itself. And she has never been admitted for ketoacidosis before. That matters, because it tells you this is likely a straightforward, if severe, insulin deficiency crisis. And it points your search for a cause squarely at those 2 days without her medication. Here are the cues that count. First, the triad that names it, a glucose of 642, large ketones, and a pH of 7.16, diabetic ketoacidosis. Second, the Kussmaul breathing, deep and fast, the body trying to blow off acid. Third, the signs of a massive fluid deficit, the dry, tenting skin, and the racing heart. And fourth, the one that sets your order of operations. A potassium of 5.8 that looks high but hides a total body depletion. Put them together and the lesson is clear. This is a fluid and potassium emergency before it is an insulin one. Fluids first, check the potassium, and only then insulin. Step 2. Analyze the cues. Take each finding and ask not just what it is, but what it means, and whether it can be trusted at face value. The glucose and the ketones and the acidosis are alarming, and they are meant to be. But the finding that will trip a rushing nurse is the one that looks fine. So sort them honestly, Which of these can you take at face value, and which are more dangerous than they appear? Hold the potassium, especially in your mind. Sort them, and the theme is that the surface is deceiving. The glucose of 642 and the large ketones are exactly as bad as they look. The pH of 7.16 is a severe acidosis, no hiding it. The dry, tenting skin signals a fluid deficit of several liters. But the potassium, 5.8, is the trap. It reads high, which might tempt you to worry about too much potassium, when in truth, the total body is depleted, and this number is about to fall through the floor the moment insulin drives it back into the cells. The analysis gives you your rule. Correct the fluids, respect the potassium, and never let insulin get ahead of either. Step 3. Prioritize. Name the one problem and the one first action that everything else depends on. And feel the pull of the obvious answer. She is a diabetic with a glucose over 600. So surely the priority is to bring that sugar down with insulin immediately. Others might fixate on the acid and reach for bicarbonate, or on the high potassium and try to treat it. Each of those, chosen first, can harm her. So ask, what is killing her fastest? And what single action addresses it without triggering a new emergency? The priority is her profound volume depletion and acidosis, and the first action is fluids. Isotonic saline, not insulin. Here is why. She has lost liters of fluid. Restoring that volume alone begins to lower the glucose, improve perfusion, and support the pressure. Insulin is essential, but it is not first, because given before fluids and before you know the potassium, it drives potassium into the cells and can cause a fatal arrhythmia. Bicarbonate is not the answer either. The acidosis corrects as you treat the underlying process. And the high potassium is not a hyperkalemia to chase, it is a warning. Name it as a fluid and potassium emergency, and the first bag you hang is saline. Step 4. Generate the solutions. Lay out everything that belongs in the plan. This is select all that apply. Start with what refills her isotonic fluids aggressively. Before any insulin, check the potassium because it decides whether insulin is safe to start. Then insulin, as an infusion once the fluids are running and the potassium is at least 3.3, add potassium to the fluids as the level falls with treatment, and when the glucose comes down toward 200, add dextrose so you can keep the insulin going to clear the ketones without dropping her sugar too low. Then the traps, an insulin bolus as your very first act, or routine bicarbonate for the acid. Gather what heals in the right order, leave the shortcuts behind. Here is the plan. First and foremost, isotonic saline, and plenty of it, to restore the volume she has lost. Check the potassium before you start insulin. If it is below 3.3, you hold the insulin and replace potassium first, because insulin would drive an already low potassium dangerously lower. Once fluids are running and the potassium is safe, start a regular insulin infusion to shut off ketone production and close the acid gap. Add potassium to the fluids as it drifts down, and when the glucose falls to around 200, add dextrose, so the insulin can keep running until the ketoacidosis clears. The traps. An upfront insulin bolus before fluids or before the potassium is known, and routine bicarbonate, which is not recommended and can do harm. Right actions, right order. Step 5. Take action, and in this case, the order is not a preference, it is a matter of life. One thing must come first to refill her, and to begin lowering the glucose safely. One number must be known and safe before a particular drug can start. Then, that drug, the insulin, can finally run. And one more addition keeps the insulin working without a new crisis. Sequence these the way the orders are already written, and keep asking at each step, is it safe to give insulin yet? Here is the order. First, isotonic saline, opened wide, to restore volume. This alone starts to bring the glucose down and stabilize her. Second, check the potassium, and act on it. If it is below 3.3, hold the insulin and replace potassium. If it is in range, add potassium to the fluids and proceed. Third, once fluids are running and the potassium is at least 3.3, start the regular insulin infusion. to switch off ketone production and close the anion gap. And fourth, when the glucose reaches about 200, add dextrose to the fluids and keep the insulin going until the gap closes. Fluids, potassium, insulin, dextrose. Insulin is never first, and never before the potassium. Step 6. Evaluate. You have given fluids, checked the potassium, started the insulin. Now close the loop. And here is the subtlety of ketoacidosis. The number everyone watches, the glucose, is not the number that tells you she is better. So reassess with the right targets. Is the anion gap narrowing the true measure that the acidosis is resolving? Is the glucose coming down at a safe rate? And critically, what is the potassium doing now that insulin is on board? Ask, is the gap closing, and is the potassium staying safe? Here is the reassessment. The anion gap is narrowing, from 28 down towards 16, which means the ketoacidosis is actually resolving, and the glucose has come down to 240, so dextrose has been added. But look at the potassium. It is now 3.4 and falling, exactly as predicted, as insulin drives it into the cells. That names your next moves. Add more potassium to keep it safe, and do not stop the insulin just because the glucose looks better, because the anion gap has not fully closed. This is the classic error, stopping insulin when the sugar normalizes while the acid is still there. Keep the insulin running until the gap closes, replace the potassium, and only then transition to subcutaneous insulin, with an overlap. The glucose was never the finish line, the closed gap is. Let's tie the case together. Your cues: a glucose of 642 with large ketones and a pH of 7.16, the diabetic ketoacidosis with Kussmaul breathing. Deposit. Your action: treat it as a fluid and potassium emerts isotonic saline before insulin, check and protect the potassium. Start the insulin infusion only once fluids are running and the potassium is at least 3.3. Add dextrose near 200 and continue until the anion gap closes. And the outcomes you are steering toward? Volume restored, the gap closing, the potassium kept safe, and no insulin-driven crash. Recognize, analyze, prioritize, generate, act, evaluate. The instinct was insulin first, the answer was fluids first, and potassium before insulin. Now, the next patient. An older man, a type 2 diabetic, brought in confused and barely responsive. His glucose is not 600, it is over 1000, and yet his ketones are almost absent, and his blood is not acidic. He is dry, dangerously dry, more depleted than his blood pressure lets on. This is a different beast, and the paradox is that the danger is not only how high the sugar is, but how fast you are allowed to bring it down. Correct him too quickly, and you can swell his brain. 6 decisions, that is case 206.